the importance of prospective cohorts in understanding aging outcomes in HIV. And in the second half of the talk, I really want to focus on how investigators can leverage the wealth of data and the infrastructure of ongoing prospective cohorts to answer important aging-related questions. And I'm going to focus a lot of my talk on two ongoing cohorts, the MACS, which we have heard a lot about today, which stands for the Multi-Center AIDS Cohort Study, and then the WISE, the Women's Interagency HIV Study. So, I want to begin by saying clinical observations in HIV-positive patients are a major driver of the questions that we study in cohort studies. And I want to talk a little bit about the lipodystrophy syndrome from the perspective that, when the adipose tissue changes, insulin resistance, and dyslipidemia came out in clinical case reports, when they surfaced, the cohorts responded by beginning to do research looking at the association of HIV and antiretroviral therapy with these metabolic perturbations. And these are typical of aging as well. So, it was because of this that Todd Brown published one of the first studies in the MACS cohort that showed that HIV was associated with an increased incidence of diabetes. And this was soon followed by, the same finding in the Women's Interagency HIV study, and then using the Partners Healthcare database, Virginia Truant was able to show that HIV was associated with increased acute myocardial infarction rates, and then she also showed that perhaps in women it was actually even, more increased. So other cohorts, such as the Kaiser database, have shown that HIV infection is associated with an increased risk of cancer, especially of infectious causes. The HOPS cohort later on showed that their HIV was associated with increased rates of bone fracture, and this was compared to the US general population. And then Greg Kirk in the ALIVE cohort showed that HIV hepatitis C associated, HIV hep C was associated with increased liver fibrosis severity, and perhaps this was occurring 10 years earlier compared to those without HIV. And then more recently, there have been longitudinal studies looking at falls in HIV-positive and negative women and the role of cognition. This is work by Anjali Sharma in the WISE. And then also from the Veterans Aging Cohort Study, the VAX, they've also recently shown that HIV infection is associated with an increased risk of heart failure. So, I hope I've conveyed to you that prospective cohorts serve as an excellent vehicle to examine aging outcomes in HIV. But I do want to point out that not all cohorts, are equal or alike, as we know. And so I want to talk a little bit about some of the differences between cohorts. So, I think they can be generally categorized into clinical cohorts, where the source population is from the clinical setting, and the type and timing of the data is determined by ongoing care for the patient. And so these include like the CDC-funded studies, the HOPS HIV outpatient study, and the SUN study. Unfortunately, these are no longer actively no longer active cohorts. And there are also electronic medical record-based cohorts, such as CNICS, and as I alluded to earlier, healthcare system-based databases, such as the VA, Kaiser, and the Partners Healthcare System. So, some people feel that, this may be slightly biased, these type of cohorts, because they are tied to clinical care. And so the other type of cohort that I want to talk about are the interval cohorts. These are where HIV participants are enrolled without respect to clinical care and followed at specified intervals. These are usually, investigator-initiated and driven, and there is usually a comparable seronegative at-risk group of men and women, and they are diverse in geography, race, ethnicity, and co-infections. And then there is also a substantial existing database and specimen repository. And so this is the type of cohort that the MACs and the Ys are. And we did hear yesterday from Dr. Lang, and I will confirm that, in 2019, the MACs and Ys, it's planned to become a combined cohort study. So I want to take a few minutes to talk a little bit about the MACs and the Ys. So the MACs was established in 1984. It was really a cohort of MSM, and they have enrolled a total of 7,352 men in, I think, 3 different waves of enrollment. WISE was established in 1993 and has enrolled a total of 4,982 women over 4 waves of enrollment. So, this is just showing the MAC sites. There are 4 clinical sites. They're in Baltimore, Pittsburgh, Chicago, and Los Angeles. In terms of the Y sites, there are actually 9 clinical sites. Starting in San Francisco, there was an LA site, which is why this is purple. It's a mix of blue and pink. And they were actually discontinued to make way to our southern sites because of the changing geography of the HIV epidemic, the move to the southeastern part of the United States. We also have sites in DC, New York, and our data center for both the Ys and the MACs are housed at Johns Hopkins at the School of Public Health. So just a little bit more about the characteristics. Currently, the MACs and Ys follow about 2,300 participants in each cohort. In terms of MACs men, about 75% are over the age of 50. And then half of WISE women are over the age of 50. WISE women predominantly are Black or Hispanic, and then about a little over a third of the MACs men are Black or Hispanic, and that is purely, it's really a reflection of the HIV epidemic in the United States. And, just to say a few other words, in terms of HIV characteristics, about 75% of MACs and WISE participants have an undetectable HIV RNA, and then probably the majority of both MACs and WISE have CD4 counts over 500. So I want to talk a little bit about the data that is collected in terms of utilizing MACs and WISE as a resource. So MACs and WISE see participants every 6 months, and they fill out a battery of study forms, including demographics, psychosocial, history, behaviors, medical history, medication use. Some of the medications data that we gather include antiretroviral therapy, of course, hepatitis C, direct-acting antivirals, and CVD-related meds, including metformin and statins. And in WISE only, we also capture OBGYN history information as well as health services information. In terms of the physical exam, both cohorts do anthropometry measurements, blood pressure measurements, and phlebotomy to test for metabolic liver renal parameters and an HIV RNA. The WISE also does a GYN exam, and they also do serial testing for anti-Müllerian hormone levels. And so this is actually a biomarker of ovarian reserve, and it becomes undetectable 3 to 5 years before the last menstrual period. So in WISE, we have been able to really characterize the menopausal transition and how it's impacting on a variety of age-related outcomes. So we have studies looking at the menopausal transition and bone issues, liver. We're also now looking at cardiac-related outcomes. And so in addition to blood, we also collect and store urine and DNA, and the WISE also collects cervical vaginal lavage and hair samples to test for antiretroviral exposure levels. And then for outcomes, we gathered this data from self-report, medical record review, registry linkages to the death registry, cancer registry, TB, and end-stage renal disease registries. And so this is for both MACs and Ys. And we have, a big component of our exam is related to sub-studies. I mean, our exams can be 4+ hours every 6 months. And a lot of these sub-studies are driven by R01 funded grants or by NIH supplements. So, for example, you can kind of get an idea of what some of our research priorities are right now in the Ys by looking at some of the sub-studies that we're doing. So there are quite a few cardiovascular initiatives. So we do Ys-wide ankle brachial index measures to assess peripheral arterial disease. We're about to embark in the next year on a Ys-wide studies, doing EKGs, cardiac echo, pulmonary function tests. We've been doing frailty assessments. We have an R01 looking at hepatic steatosis and fibrosis progression using FibroScan that is Ys-wide. We also have an R01 looking at novel urine biomarkers of kidney injury that could be representative of subclinical kidney disease. And at select sites, we also have R01 grants looking at bone microarchitecture and density using MRI, CT, and DEXA. We also have a liver MRI study. MACS similarly has several of the same ongoing studies. We collaborate already on a lot of these initiatives. So they also have the EKG, echo, PFT, frailty studies. They're also doing sleep studies. And then they've also got some detailed imaging studies using cardiac CT, brain MRI, also at specific sites. So finally, we also do neuropsych testing in both cohorts. MACS also gathers data on dementia and peripheral neuropathy. And in the Ys, we gathered additional data on PTSD. So what I want to do in the next few slides is to highlight some of the work that's being done by investigators in Ys. A lot of these this work is actually in collaboration also with the MACs. And it really shows how investigators can leverage the Ys and MACs platform to implement studies. So this is work by Robert Kaplan, who is a cardiovascular disease epidemiologist at Albert Einstein, who is actually now the chair of our CVD working group in the Ys, who actually started his career in HIV and cardiovascular disease by implementing a longitudinal CIMT study. So CIMT is carotid intimal media thickness, which is a marker of subclinical atherosclerosis. And then he later went on to utilize our specimen repository to really answer novel, questions about mechanisms of the pathogenesis of CVD in our HIV positive women and negative women. So this is just a recent publication in JID that was led by David Hanna, who's sitting back there, who works in Robert Kaplan's group. And what they found here was that soluble CD14, a marker of monocyte activation, was associated with increased carotid plaques that were defined using the CIMT over 7 years. So, he found this in the Ys, which is his first bar, the MACs, which is the second one, and as a pooled cohort. And these are the different models showing that, after each adjustment step, that association still remained. So this was adjustment for HIV only, additional adjustment for demographic behavioral factors, additional adjustment for inflammatory markers, and then the final step was adjusting for cardiometabolic factors. So, what I want to point out here too is the richness of the data in our cohort, allowing us to control for several of these key factors. So next, I want to highlight the work of Allison Morris, who is a pulmonologist at the University of Pittsburgh. And she is now the chair of the WISE-MAX Pulmonary Working Group. And what she did was she initially utilized the core data that was collected in the WISE and MAX, and this is some of the work that she's published, to look at the incidence rates of self-reported asthma, COPD, and sleep apnea by HIV infection status. So she looked in the MAX and she looked in the WISE. And I hope you can appreciate here that the incidence rates in WISE were much higher for asthma and COPD. And so she has utilized that data now to actually be awarded 2 or 3 different R01 grants where she has now implemented rigorous studies of pulmonary function tests, bronchoscopy, and chest CT to address the factors associated with pulmonary disease in HIV, and also to specifically understand why these sex differences are occurring. So finally, I want to touch on Michelle Estrella's work. She is a nephrologist at UCSF. And she is now also the chair of our renal working group in both the WISE and the MAX. So I think if you start leveraging our cohort appropriately, we will start putting you in these leadership positions to head our working groups. So what she has utilized here in this particular study is shown that novel kidney biomarkers in the urine that are suggestive of subclinical kidney injury is actually associated with developing another cardiovascular risk factor, which is hypertension in our positive women. So, again, this is showing you how she has utilized our specimen repository of urine. And this is actually work that's also in conjunction with Michael Schlippack to answer how kidney injury markers that are subclinical can impact on other outcomes. So, I've touched only on the work of 3 of our investigators or working groups. We actually have 15 working groups in the WISE and MAX. 8 of them are associated with age-related outcomes. So, the question now is, how can investigators tap into this rich platform of data and as well as our infrastructure? And I did, show you the examples of the 3 other investigators. And I do want to say that WISE and MAX actually have no formal mechanism to award developmental funds, but mechanisms such as CFAR have funded WISE pilot awards for early career investigators. NIH administrative supplements have also funded early career investigators or investigators new to HIV. And I think that Gretchen, this morning, she was a recipient of one of the senior grants, which is for investigators that are new to the HIV field to do her work in the WISE. So, these mechanisms have actually led to a number of NIH, K, R, and program grants. And so I just want to highlight, the WISE. As of December 2016, WISE has 51 NIH-linked grants. And if you notice here, 35 of them are related to comorbidities and complications. And I really want to point out, too, that 18 of the 51 grants are training grants. So, we have 5 KL1 awards, 6 K23 awards, as well as 3 K24 awards, which are mid-career investigator awards to actually mentor the next generation of early career investigators in patient-oriented research. So that is a big priority of the WISE and MAX, to mentor early career investigators in studies. So I just want to conclude that prospective cohorts are critically important to understanding aging outcomes in HIV-infected persons. Ongoing cohorts, such as the WISE and the MAX, provide an excellent platform for investigator-initiated research. And, I want to point you to these 2 links. This is our WISE website and our MAX website that you can take a look at. I'm going to show you a little bit more from our WISE website. So if you are an investigator and you have a question and you're very interested in utilizing our study, open up the link, go to investigators, which is here, and then under investigators, there's an investigator how-to section that tells you about proposing new study analysis, requesting data and specimens. We do have a concept sheet form process, actually both WISE and MAX. And then if you're interested in publications, there's a searchable database for WISE and MAX publications as well. So I just want to conclude to say that none of this would be possible without NIH, and all the different institutes and the Office of AIDS Research for supporting the WISE and the MAX on all these different research endeavors. Thank you.